Welcome to Tuesday, April 9th of 2024. It's time for Tuesdays with Tina. And today we're going to be talking about administering local anesthesia with our patients who might have some challenging anatomy and also might have a little bit of facial reconstruction. So this topic comes from a listener, and thank you, I appreciate that. Comes from a listener who had asked a question about giving injections for those individuals who have had some sort of facial implants or facial reconstruction completed and how we address those situations. And it also piggybacks on with other questions that I receive about doing injections for patients with challenging anatomy, especially in that nice big tongue. So that's our topic for today. Hello, Facebook. Happy to see you over there. And hello, Instagram. Happy to see you guys here as well. And as a reminder, these do get recorded and put on the Teacher Tina RDH YouTube page. Now, before I really dive into this week's topic of doing anesthesia for our patients with that challenging anatomy and who've had lip implants and cheek implants or all the things to tighten everything up. Last week I talked about POTS, P-O-T-S, postural ortho. Now I just lost the name of it in my head. POTS, basically postural orthostatic tachycardia. And since then, I've had a few people come and reach out to me sharing their own personal stories with them individually or family members. And I've been given some research articles, and one of them I haven't read yet, but the title was interesting. It was about how mold toxicity can show up as POTS. So if you know somebody like that, that will be interesting. I'm going to read that article here probably in the next week or two, but I thought I'd share that information. And thank you guys for reaching out with that, with your thoughts and your comments and your experiences with that. So I really appreciate it. All right, so let's really dive into today's topic, which is, how do you do injections with people with challenging anatomy, especially if they've had some sort of implants? Sorry, you hear the cat in the background. Sorry about that. First, I want to say, let's start off with the most common challenging anatomy that we have with our patients, and that is if they have a very large tongue, right? If you have a patient with a really large tongue, makes it makes it so challenging, so very hard to see, especially when we're doing a mandibular block, like an inferior alveolar nerve block, and their tongue is so huge and oversized. Which, by the way, there's issues. They've got issues. If their tongue is that big, you might want to be having a conversation with them about sleep apnea as well, and what some of those causative factors are, what some of their health systems, and maybe ask if they've connected up with a functional health medicine doctor specialist, because there's a lot we're learning about tongues right now. Anyways, if you have a patient who has a really large tongue, some of the things you might want to think about, and I left the mandible out of reach. Some of the things you want to think about is, instead of doing an IA for those individuals, because you cannot see very easily, you might want to think about doing a Gauguin injection or a Vazirani Akinosis, which is the closed mouth mandibular block, which is kind of levels with the maxilla, but it is a mandibular block. You can go back to some of the other recordings that you can refer back to some of those. Again, just go to the YouTube page and you'll see some of those on there. And if they're not already on there, let me know and I'll go through some of my history and upload them. Anyway, so you can do an alternative mandibular block injection for them. Vazirani Akinosis, that closed mouth technique, really does help quite a bit. So that's one option that you can do for our patients with a really large tongue. You could always, do mandibular infiltrations as well. If you do that, Articaine all day, every day. I love it. I love Articaine even for my mandibular blocks. It's safe, it's effective. It's time we got to kind of debunk that. All right, so there's the big tongue issue. If your patient cannot open their mouth very wide, again, using some sort of the closed mouth technique, you might be able to make that happen as well. Now, for our patients who maybe have had some lip fillers or lip implants, cheek implants, or they've had some sort of facial reconstruction, that can make it a big challenge when we're doing our injections. So first off, this is one of the things I want to challenge us as dental professionals, is to add these kinds of questions into our history intake questionnaires with our patients, as far as what type of Procedures have they had on the head and neck region, including cosmetic, whether it is by choice or by necessity, if they've had any kind of cosmetic facial alterations at all. Because, right, this is our area. We need to know that. We really need to know. And it's important to follow up then, like what kinds of complications did they have with any of those items as well. So just a food for thought, have these questions with your patients. If it's not already on your health history, you can always just pose the question. Especially if you have a new patient, I always say, hey, do you have any dental implants, any endodontic work, anything like that I need to be aware of prior to starting your imaging or anything like that. Ask them if they've had any type of facial reconstruction, if they've ever had any lip fillers, if they have had cheek implants, even Botox, if they've had any Botox done, because that will change how their face functions. It'll change what it feels like for us as well. The other thing is, when you do find that information out, palpate. Really feel along the area that has been altered or has received treatment, and get an idea of how tight their tissue is, and how long ago it was. Because if it was a while ago, they might have full function. But if their surgery is still fairly recent, within 2 or 3 months even, they could still be in this healing process, and we might see some scarring around their mouth. So have a great dialogue with them. Palpate the area really well. You'll want to make sure that, especially if there's any type of cheek implants or anything like that, that you get a really good idea of the zygomatic alveolar process, so you know where that is at, and feel for that zone. If you have access to any kind of imaging, use that as an aid for yourself, so you know where the anatomy is at, what you're looking at, whether it is ideally if we get to see even like cone beam, where we can really see multiple different layers, might be able to see some of that information on the imaging as well. The other thing is, if they've had all of that done, it might be really challenging to pull their lips out of your way and keep your fingers safe. Now, I am a person, I love using my own hands to retract. And I know this is a trend that we're seeing now, where we're not using our hands, which is very, very safe. We're using retraction devices. And for these individuals, that might be something that you want to do. Maybe you're going to use your mirror to retract, so that way it's thinner and it gives you more space to insert the needle. You might be using a Minnesota retractor, a tongue blade. There's also retraction devices out, like the DentaVibe is a retraction device that you can use, which will retract the lip and also do some vibration for you as well. And then it has a nice grip on it, so you can get that nice tight pull as well. So those are some of the things to be thinking about if you have a patient that has had any type of cosmetic surgeries to their face, to their lips, to their cheeks, in order to, if you have to anesthetize them. If they've gone through all of that, this is probably also somebody who might have a little extra care about their teeth. So this is good that they're coming in and seeing you. When it comes to if they've had some sort of traumatic event, and they've had to have facial reconstruction due to a traumatic event, that could completely alter the way that their nerves are. You guys, I'm really sorry, but my cat is the cat is like just messing with the curtain off camera, and almost pulled the curtains down on me. Sorry, I digress. But if your patient has had any type of facial reconstruction, that could be an issue to be aware of as well. And again, imaging will be very important. Their neural flow might be a little bit different if they've had something like that, okay? If they've had any kind of like jaw resection, if they've had the Lefort surgeries as well, where they have had to take a Lefort surgery, basically they take the maxilla, cut it, and move it around like it's a partial or a denture. Move the maxillary teeth into position where they want to be, and then they'll usually resection mandibular right and left. Move the mandible where they want it to be. That can create a different nerve flow for our patients. And you might even feel or see in the imaging I'm going to say nuts and bolts. Basically, that's kind of what they are. But you're going to see the surgical plates and the surgical screws that are used, and that could potentially impact your anesthesia as well. So important, have a dialogue with your patient, take a look at that imaging, really palpate that anatomy, and you might have to use some retraction devices as well. All right, so again, this was requested from a listener who asked if I would touch on that, and I combined that with some other questions that I've received over the years. I love it when you guys ask questions. It's wonderful. I think it's amazing. And with that being said, I do want to say I still have a few minutes here that I'm available. I had another question come up after the medical emergencies course that I gave a couple of weeks ago. And one of them was needing clarification on patients' medications. If we're using their medication or the office's medication if there's a medical emergency. And I just want to reiterate for anybody that's ever seen a medical emergencies course, or has looked into any of that kind of stuff, always remember to use your patient's medication first. If they have it with them, use their medication first before having to dive into what you might have in your medical emergency kit. So just want to throw that out there. If your patient has their medications with them, make sure you're using their medications. That's what's been diagnosed for them. It's properly dosed, and we know that works for them, instead of, in the case of an emergency, break here, open up the vials, and use those. So, which could always happen. All right, friends, thank you so much for being here, for sharing your thoughts, your stories with me. I truly appreciate it. I appreciate you sharing your questions and for sharing this with your friends. I recently just made over 5,000 followers on Instagram. Thank you so much. And I'm really hoping to get more followers on YouTube as well, to be able to bring more amazing stuff. And if there's things that you want to know about anesthesia, outside of anesthesia, please feel free to ask, and I will do my best. If I don't have the answer, I will find somebody that does, just like I did with our infection control awesomeness that we had a few weeks ago with Amanda Hill and Michelle Strange. And you can watch that one on YouTube as well. All right, friends. Really, from my heart, everything I do is from my heart, and I appreciate you being here, and until next week, bye-bye.